Patients have many different frontline options. To date, I think there is yet to be definitive or evidence that one regimen is better than the other. And what I mean by that, there are randomized trials looking at CVP versus CHOP versus fludarabine-containing regimens. It appeared that fludarabine is more toxic, and CHOP had a longer progression-free survival. But if you look at the overall survival of these three different regimens in randomized trials, it's very, very similar. If you look also at randomized studies of bendamustine rituximab versus R-CHOP, there's a German trial which suggests there is significantly longer progression-free survival using bendamustine instead of CHOP. And there was another randomized study called the BRIGHT trial, which they also looked at R-CHOP, R-CVP versus bendamustine rituximab. And there appeared to be very similar overall responses, very similar complete remissions, maybe a little bit longer progression-free survival with bendamustine rituximab, but again, no dramatic difference in overall survival. And what that kind of tells me, I think, is that many of these combinations are very active in patients. The timing of one agent versus the other may not matter as much. And what I mean by that is if a patient gets CHOP first followed by bendamustine or vice versa, the long-term outcomes may be very, very similar. So when I'm thinking about how to treat a patient, I think all options are on the table. So that means explaining to the patient the different side effects of different regimens, talking to the patient about the length of treatment, talking to a patient about the different studies is important, and looking at the patient's comorbid conditions, i.e. clearly a patient that has pre-existing cardiac disease would not receive an anthracycline that is contained in CHOP. So unfortunately, there's no great answer. Again, in my opinion, there's not definitive evidence that one regimen is better than the other. They all look efficacious in this type of disease, and the treatment decision should really be individualized to the patient.
The subcutaneous form of rituximab is called Hycela. It's a very exciting development in lymphoma management because it lowers the time needed to administer rituximab for patients. And that's really important because the first infusion of rituximab typically takes 4 to 6 hours, depending on the reactions that a patient has, needing to pause the infusion. Subsequent therapies of rituximab go for 90 minutes. But the nice thing about Hycela, which was recently FDA approved in June, is that in a matter of minutes, 7 to 10 minutes or less, a patient can receive rituximab under their skin, and that's because it has a special molecule in it that permits absorption under the skin. Patients love it. It lowers their time in the office dramatically. And in my opinion, it actually lowers the infusion reactions because there's no infusion. Patients do, in my experience, have a small area of redness on the skin and a little bit of discomfort, but in a matter of days that completely disappears. And for patients that are getting maintenance Rituxan that have to come in often, it's a life-changing event because they actually are in and out of the office really quick. And the studies have shown that there's absolutely no difference in survival between the subcutaneous Rituxan and the IV Rituxan. So that makes it really appealing for everyone, including myself.
Recently, we saw the approval by the FDA of biosimilar Rituximab. And this could change the market. I do think we are going to see some practices switching to generic Rituximab based upon data that really looks very, very similar between the two. I think that, with the rising cost of pharmaceuticals, we're going to see a lot of people, both in clinical practice and in academics, switching to generic forms of several drugs. And we're seeing several generic versions of drugs emerging into the market. And I think, honestly, it's just a matter of time before we'll see practices switching to generic forms of these drugs, especially with randomized phase 3 trials suggesting that there's really similarity with regards to both primary and secondary outcomes with these drugs.